Welcome to the Ibex Medical Analytics seminar on HER2, and specifically we are going to address the topic of challenges in interpreting HER2 Low and practical applications in real-world settings. So we have a very nice panel of speakers today who will address this very interesting topic, and starting with our own Chief Technology Officer and co-founder, Dr. Chaim Linhart.
Yeah, so USCAP guidelines. Find the number of cells with each staining pattern compared to the 10% threshold, and you have the HER2 score. Sounds easy, right? That's what we thought. We were wrong. But to test this, and to see how AI can help, we are running a very large early evidence program together with our partners from AstraZeneca and Daiichi Sankyo. So this program is running at 15 sites around the world, and you'll hear two of them, MD Anderson and Cambridge, after me. So how often do pathologists agree on the HER2 score? That's one of the main questions we wanted to ask. And currently we collected data, results from 8 labs, a total of 1,200 HER2 slides. And these are all comers, so we didn't enrich them specifically for difficult cases. All the pathologists participating in this program received training and were requested to strictly follow the USCAP guidelines. So no other clinical considerations or anything else, just the guidelines. And these are the results. On average, pathologists agree on the HER2 slide level score only 77% of the time. And that's quite low. And of course, this could have implications on treatment decisions and so on. So why is the concordance so low? There are, of course, many explanations, and here are a few. So challenge number 1, we have various types of tissue preparation artifacts, like torn tissue, folds, out of focus, and so on. And maybe more importantly, there are staining artifacts. So for example, if you have basal staining or cytoplasmic staining, you need to ignore those, and you need to only look at the membranes between the cells that are stained. So that's one challenge. Another challenge is that you need to find all the invasive tumor areas, ignoring, of course, DCIS, and then you need to estimate the percentage of cells across the whole tumor, which could be very difficult if you have a large tumor. And maybe even more difficult is that sometimes the staining isn't uniform across the tumor. So you could have different distributions, different staining patterns in different regions of the slide. And you need somehow to combine all these percentages in your head and then be able to compare it to 10%. And of course, that's not easy. So here you have 2 examples. One example is a large tumor with 500,000 cells. So imagine estimating percentages over 500,000 cells. And you can see here results by 3 senior pathologists. So the results are different slide level scores, but also different percentages, in this case for the moderate complete or intense complete cells, very different percentages by different pathologists. And it's not just the huge tumors that are a problem. Here we have only 5,000 tumor cells and still low concordance between pathologists. So the point is, it's not just the very, very borderline cases where you have 9% or 11% cells, and you don't know if it's above or below the 10% threshold, but also seemingly more simple cases and a huge variance between pathologists. Challenge number 3. So how do you classify the cells themselves, the individual cells? Does a cell have faint staining or weak? Is it moderate or is it intense? Is the membrane complete? Am I seeing cytoplasmic staining, basal staining, or is it true membrane staining? So what we did, we selected several slides and we marked regions of interest, ROIs, within those slides. You can see here an example. And we asked pathologists, again, very experienced pathologists, to annotate and label all the cells in those ROIs. And when we compared the results, we saw that sometimes the agreement, as in this case, was as low as 30%. So only for 30% of the cells, the pathologists agreed on the staining pattern of that cell. Of course, not all of these differences have a clinical meaning. For example, if it's a moderate incomplete or faint incomplete, it doesn't really matter, but it does show you the subjectivity of identifying individual cells. So to address these problems, of course, at Ibex, our solutions are to use AI. So we have the Galen platform with AI algorithms for prostate, breast, and gastric H&E slides. And these solutions are deployed around the world, used in clinical practice. And specifically for breast, the AI on the H&E can identify more than 50 different morphologies or features. We have very high accuracy for morphologies like invasive carcinoma, DCIS, many others. Maybe some of you attended the symposium yesterday, so you heard about these solutions. So what we did, we added AI for HER2 to our Galen breast platform. How does it work? So the first step, we use a machine learning model that identifies the tissue as well as out of focus tissue that we want to ignore, and different types of like background artifacts like cracks, air bubbles, and so on. Once we have the tissue, in step 2, we exclude the on-slide control. And then in step 3, we run an AI algorithm that identifies the invasive carcinoma. This model is basically, it's based on our H&E technology. So it too can identify different morphologies, not just invasive tumor. Of course, specifically here, we made sure that it can identify DCIS very accurately, so we can ignore it from scoring. Sometimes it has a different staining pattern. This algorithm, this AI, was trained by pathologists using more than 20,000 annotations, so annotated areas that were labeled by pathologists. Then we take the invasive tumor that we detected, and inside those areas, we run another AI algorithm, a different one, which identifies the individual cells, the tumor cells, and classifies their staining pattern. Is it faint? Is it moderate complete, intense incomplete, and so on. So actually, it supports all the major staining patterns, and it can also identify different types of artifacts, like ink and cytoplasmic staining, and so on. This algorithm, just to give you a sense of the effort, it was trained on more than 400,000 cells that were manually annotated by pathologists. Finally, in step 5, we just count all the cells, and we follow the USCAP guidelines to reach the slide level score. Here's an example. Okay, so it'll be difficult to see on the screen, so yeah. But trust me, we have the HER2 slide. Then the AI runs on that slide. It identifies the control on the right side. And in the middle, you can see in blue, that's the invasive tumor. If we zoom in, okay, that's a little bit better. Then you can see a mix of tumor cells. So those that are not stained are marked by blue circles. Those that the AI thinks have faint staining are in green. Yeah, and on this screen, maybe barely perceptible is really barely perceptible. But yeah. And then we have the small black dots, which are the non-invasive or non-tumor cells. Okay, so how does the AI handle all kinds of challenging cases or problems that we encounter in these slides? So here you have two examples. On the top, you see a tissue that is slightly out of focus, and the AI found this invasive area, but it marks all the cells with these small purple, you can't see that they're purple, but they're purple circles, which means that they are unclassified. So if the AI thinks that it cannot reach a reliable classification, it just ignores those cells. It's better than to give an incorrect classification. The second example is, has a thick and somewhat crushed tissue. So some of the cells, the AI was able to classify as not stained cells, but those that have some brownish background, the AI wasn't sure how to interpret them, and it, again, marked them as unclassified cells. So it's important for AI to know its own limits, not just to give an answer always. Next, we have staining artifacts. So the first example, we have basal staining. I don't know if you can see it, but the basal staining is still mostly ignored by the AI, which classifies the cells as not stained, so blue circles. And the example at the bottom, so we do have some faint cells. You see membranes, but some of the other cells only have cytoplasmic staining, and they are classified correctly as not stained. Invasive area detection. Here we have, I think, very nice examples. One is a 3+ slide, the other is a 2+. And in both cases, the algorithm was able to identify the invasive part. I hope you can see it, and very elegantly skip the DCIS. Another nice example, so here we have the H&E slide. The H&E AI algorithm detected the DCIS, which we can clearly see, but if we zoom in, we see a microinvasion, and they're caught by the invasive heat map on the H&E. And if we look at the HER2 slide, this is really cool. We have, I think Professor Schnitt called it a micro invasion or something like that. So it's really, really small, and it was caught by the AI. So the AI ignored the large DCIS and caught only the invasive component. And this just shows you the sensitivity of the algorithm. Now let's look at a larger, a full example. So here we have an excision with DCIS and some adenosis. And of course, at the top, we have the invasive tumor. If we zoom in, this is the H&E for the invasive tumor, and this is the HER2. Okay, it's pretty faint on the screen. And you see the results by 4 pathologists. So it's somewhere between a 0 and a 1+, but even for 1+, different pathologists found a very different percentage of faint cells. And these are the AI results. So the AI found the invasive tumor, skipped the DCIS, and it actually counted only 4% faint cells, so it gave it a score of 0. I chose 2 areas that have the most staining to zoom in and show you how it looks like. So these areas, again, I hope you can see something, but they have some faint cells, so you can see some membranes, but most of the cells don't have any HER2 staining. There is some blush, but it's not membranes. And the AI indeed found some faint cells, but most of these cells are not stained. And when counting across the entire tumor, the AI found 4%. Okay, so back to our first question. How often do pathologists agree on HER2 scoring? So we took the same cohort as before, the 1,200 cases from 8 labs. And this time we had 2 arms. So the readers reviewed the slides with and without AI. And we compared the concordance between pathologists in each arm separately. And the results are these. So again, without AI, low concordance, around 78%. With AI, the concordance increased very, very significantly to 90%. So we have a very significant increase in the consistency of HER2 scoring, which then allows us to, to do lots of things, to train better, to realize what is the actual accuracy of these pathologists, and so on. And finally, the conclusions. So first of all, HER2 scoring is challenging, of course, due to various reasons. And the result is that we have low, I would even say very low inter-observer agreement, typically between 75 to 80%, even between very experienced pathologists. This is challenging even, for example, if we want to establish a reliable ground truth to check the performance of AI or pathologists. How do we establish a ground truth with this kind of agreement? Is majority of 2 out of 3 enough? I'll leave that as an open question to the audience. Ibex developed a fully automated AI-based solution for HER2, and I showed you some of the capabilities and how it can cope with challenging cases. And it was trained on very diverse data sets. And the benefits, we saw significant increase in consistency and in concordance. We also showed higher accuracy and confidence in scoring, and of course, productivity gains as with any AI-based solution. Okay, thank you. And now for the experts. Thank you.
Thank you, Chaim. This was enlightening as to how the AI works. And now I'm inviting Dr. Elena Provenzano from Cambridge University Hospitals, who will deep dive into how AI can support the HER2 scoring in a real-world setting.
Thank you very much, Manuela, and thank you for inviting me to speak today. So, as Manuela's mentioned, my name's Elena Provenzano. I'm the lead breast pathologist at Addenbrooke's Hospital in the United Kingdom. So the UK, as many of you may be aware, has a nationalised health service that has some advantages in that there's been a big investment in digital pathology, particularly in district general and community type hospitals, because we have huge workforce issues, and digital pathology and AI is seen as being a solution to those issues. So our department is fully digitised now, but I will confess we're not routinely using the AI. My main experience with the AI has been through the trial, but I'm going to present you some of our own hospital data with respect to the trial and the types of cases where we've found this most useful. So, as already mentioned, there has been a big evolution in our approach to how we score HER2. So before the Destiny study, really we were looking for cases with amplification and high-level expression of HER2. So the 3+ cases and the 2+ cases, where the final classification depends on whether or not the FISH shows gene amplification. Of course, that's been refined now with the Destiny study that shows benefit of the antibody-drug conjugates in the group of patients with very, very low expression. And that creates huge challenges for us as pathologists, because I guess we're stretching the test to the limits of what it's designed for, but it's also focusing our attention on a group of cases where I think historically 0-1+, we didn't pay too much attention to that. That was negative. We didn't really have to agonise over precisely how to classify it. Of course, in both the USCAP and the UK guidelines, that's changed, and we now recognise this concept of HER2 low, which is the group where we have got some level of HER2 expression. It's not that high-level expression that would determine positivity in terms of eligibility for a lot of the conventional anti-HER2 targeted therapies. It's these much lower levels of expression where we now know there's potentially benefit from these new group of drugs, the antibody drug conjugates. So the specific group we're interested in are the 1+, which has that faint and incomplete stain and that 10% cutoff. And hopefully, as I'll show you shortly, it's really that cutoff that creates a lot of problems for us as pathologists in terms of reproducibility. And I think the 2+ group is a little bit easier for us because we've got that reflex ISH test that puts them into either the positive or the negative category, although ISH has problems of its own, but that's not the scope of what we're going to talk about today. So it's all about assessing membrane staining, and there are two features of membrane staining we need to look at, which Chaim's already elegantly presented. So it's the intensity of staining, and there's I love the concept of looking at which sort of power in terms of working out the strength of staining. So as most of you know, if you've got a 3+ case, you already know it's 3+ before you put it under the microscope. You look at the tray and you can tell that it's going to be 3+ staining, although you do have to be a bit careful about the apocrine ones where the cytoplasmic staining can mislead you. The moderate intensity you should be able to see down the 10 times. If you've switched to digital, you do need to be a little bit more careful. We've found with the digital HER2 slides, you tend to see more staining, I think. So I think if you're looking at it digitally, I would suggest for moderate staining to stick to the 10 times. But for moderate intensity of staining, you should be able to easily see it and recognise the pattern with that 10 times objective. And then for the faint, weak staining, it says 40 times here, but again, digitally, I wouldn't go beyond the 20 times staining. I think you then start to see a lot of artefact if you're looking at digital slides. So I find that the objective where you can definitely see the staining and interpret whether it's complete or incomplete is a handy way to help you make those decisions about how to label the intensity. And then, of course, the second decision is whether it's complete or incomplete. And in the future, we may have to disregard that 10% cutoff, which I think may be useful for a lot of us, because there's a suggestion that even cases with very low, less than 10% weak expression may also benefit from these new drugs. We're waiting for the results of the DAISY trial to show us that. So the HER2 low group is a significant proportion of cases. It probably represents around 45 to 55% of all breast cancers. And we have assessment challenges. So I will briefly touch on technical reproducibility, because obviously that's the elephant in the room. You know, tissue quality is very important. We know you get different results with different antibodies and different staining protocols. And I think where the AI is going to really come in and help us is with the reproducibility and interpretation. So one of my roles, I'm an external assessor for NEQAS, which is our National External Quality Assurance Scheme, looking at immunohistochemistry. And obviously we've had a HER2 module for a very long time, but we decided it was very important to have a specific module targeting the HER2 low staining. And the results of this have been really, really interesting. So we've got 45 laboratories who have enrolled for this pilot scheme. And what happens is they get sent around a slide that has 4 tissue samples that have got predetermined levels, particularly focusing on 0, 1+, and 2+ cases. They get sent round to the labs stain them using their own protocol, provide the lab's own interpretation of the staining, and then it's sort of sent back to us for review. It also includes a cell line control on that same slide. So we have a validated control to use as well. So the vast majority of labs are using the 4B5 antibody on the Ventana platform, and of those using the recommended test for this context, 56% achieve the expected results in all 4 tumours. there were 6 labs using an alternative or sort of like a home brew type test, and none of those achieved the expected results. What we were seeing was much better results using the 4B5 antibody, although obviously if you use a different test and you fully validated that, that's perfectly acceptable. For this particular run, you can see the way the interpretation works. So the first case was a 1+ case. There was 41% agreement with the reference result. The other was in that ultra-low category, so 1 + 0, around 47%. The complete negative, perhaps not unsurprisingly, was the one with the greatest concordance at 83%, and then there was a 2+ case where 42% had the expected staining results. So overall, we were a bit surprised that these are all labs who are doing very, very well on the routine HER2 module, but less than 50% were getting the expected staining results when we looked at specifically targeting this HER2 low subgroup. And as I've mentioned, the overall HER2 module, about 2/3 achieve an excellent result and a further 20% an acceptable result. So we've got a pass rate of, 88%, almost 90% with the standard HER2 module looking for the high-level staining, whereas if we specifically look at that HER2 low testing, only less than 50% were getting the expected result. In terms of scoring, just to present some UK data, so Chaim's already shown you the results from the study, but I think our results were very similar. This was a series of pathologists who sit on our National Coordinating Committee for Breast Pathologists, so it's experts, people like Ian Ellis and Sarah Pinder. In the UK, you may know those names, but it's also pathologists who act as QA advisors, a lot of whom come from district general or community hospitals. So we were given a set of 50 digitally scanned slides, again enriched for 0, 1+, and 2+ cases. The only cases where there was absolute agreement were the 3+, and there was poor agreement in 10% of cases. And those cases, the problem areas for us seem to be heterogeneous HER2 expression, so we're not very good at dealing with heterogeneity to score things. I think I know myself, I have a bias, our attention gravitates towards the positive areas. So I think in general we have a tendency to overestimate the amount of positive staining because that's what catches our eye. Not unsurprisingly, the other group that caused a lot of problems were cases that were close to that 10% cutoff, whether you were on giving it a 0 or a 1+, and then it was cases with non-specific staining like cytoplasmic staining that causes the problems. So if we combined the 1+ and 2+ as a group, the kappa value improved, but overall there was sort of low to moderate concordance in reproducibility. So the benefits of AI, I think reproducibility is obviously going to be a huge benefit, and that relates to the improved accuracy of classification, particularly when it's close to the cutoffs. As I've mentioned, the NHS, we have a slightly different situation to in the US maybe. A lot of labs outsource their in situ hybridization, and there can be a 2 to 3 week wait to get those FISH results back. So if you've got a patient potentially waiting to start neoadjuvant chemotherapy, the oncologists and the surgeons are starting to get very anxious at that. So for us, one of the things we would be hoping is that we can reduce the 2+ cases to be able to make a definitive classification on that initial immunohistochemistry and avoid further delays in treatment. Chaim's already mentioned the setup of the study. So there were, in my institution, there were 2 of us that were ground truth. So it was myself and one of our other senior specialist breast pathologists. And then we had 2 of our more junior members doing the combination of the initial review without the AI and then the review with the AI to compare the results. So that was the 2 parallel arms. So that the manual HER2 scoring was done using the digital slides. Then the readers looked at it with and without the AI. So overall, in terms of the study across all the centres, the percent agreement on all slides for the 2 experts was often quite high. Overall, it was around 90%, but Interestingly, for the individual scores, it's that 1+ group that has the lowest concordance of around 86%, with a range of 75 to 93. I'm a bit surprised by the 100% 2+, I must admit. I would expect slightly lower concordance, so it's quite interesting that there was such good agreement on that. The general pathologists, slightly lower, so 77%, but still in the same ballpark. For our own series, I guess my colleague and I have been working together for a long time. I think we've inherited each other's biases. So out of the 200, we only disagreed on 22 cases. And you can see 18 of these fell into that HER2 low category. So it was either 0 or 1+, or 1+ or 2+ for the majority of disagreements. We didn't have FISH for all of them, because I think some of these were originally called 1+, but the majority that fell in this ballpark were non-amplified, so they were negative in the end. And interestingly, the 2 cases at the 2+, 3+ were both amplified positive cases. So clinically, I think the results would have been in the right ballpark, but it's just interesting that half the cases, the discordance was at that 0-1+ cutoff, which is obviously very important moving forward for patient eligibility for this group of drugs. So just some specific examples. Hopefully they're going to project quite well. So this is an example that was called 1+ by one of the observers and 0 by the others. This is what the core looked like. So you can see obvious invasive cancer with a bit of a lobular-like growth pattern. The heat map is showing all the invasive disease, so it's being picked up as invasive by the algorithm. I don't know how well, I think you can make out there is a bit of a tinge there. So there is some definite membrane staining. This image was taken at 20 times, so it's in that weak category. I think you can see there is some definite weak incomplete staining there. But if you look at the map, so the blue circles are negative and the green incomplete circles are the weak cells. So you can see there are some cells staining, but it is the minority of tumour cells there. That doesn't look like it's reaching the 10% cutoff. And here's another area, and I think it's even harder to see, as Chaim's saying, even harder for you, that there is some very faint blush in some of the cells, but the vast majority of these cells are negative. So I think it's a bit hard to see the numbers on the edge, but it's overall saying that there's less than 10%. So this is a case that would have fallen into the ultra-low category, and the reason for the discrepancy is the difference in estimation of the percentage of cells that were staining. Another similar case, so again, core biopsy, extensively involved by tumour, all being picked up by the algorithm. I think in this one, there's more obvious staining. Most of it looks like it's incomplete. That's being picked up with those circles, the green circles with the algorithm. But there's another area where there's considerably less staining. So again, this is one of those ones with heterogeneity where the difference between the 2 pathologists was an estimate in the percentage. And overall in this case, the percentage ended up being just over 10%, and the AI algorithm called this a 1+ case. So it's the way the AI can assist us with these difficult cases where there's heterogeneity and getting a more accurate estimate of the percentage of cells that are showing the weak incomplete staining. At the other end of the spectrum are a couple of cases where the discrepancy was between 1+ and 2+. So again, there's the core biopsy and the heat map that's picking up the invasive component. Here, the staining's more obvious, but I think at the 10 times, it's a bit difficult to work out that it's complete or incomplete. I know for us, that's a big challenge for the 2+, because the categories don't really tell us what to do with moderate incomplete staining. And I think our natural tendency as clinicians is, well, we've got a second test here, let's defer to that second test to give us the answer. And hence there's often huge variation in FISH rates or 2+ rates between centres. So you can see some of these are staining up as green with the faint, but there are some with the yellow complete dots, which is complete moderate, but also lots of yellow incomplete dots, No, it's probably a little bit hard to see. And again, another area where there's still some staining, but less staining. So the majority of cells are unstained or faint. There's a few cells here with the yellow circles. So the overall classification by the AI algorithm was 1+, and actually the majority of cells with the moderate staining were ones that were showing incomplete, not complete membrane staining. Another similar case, so there's our core biopsy with the heat map. I think this one's even more obvious. So this is interesting. I'll sort of show you what's happened with the AI algorithms. We've gotten these similar answer for different reasons. So again, this is one where we've got moderate staining, but a lot of it is incomplete rather than complete. So I think it's that way of interpreting the percentage of completes and incompletes. So if you look at the heat map, there are yellow complete dots, but there are also lots of yellow hollowed out circles indicating incomplete staining. So the overall score was 2+. But the reason for the overall score of 2+, and I think that's why we still need to be careful, is the AI suggested there was a focal area of 3+ staining, and this was actually an area of DCIS. So it has picked out this one duct. And on the deeper levels, that was actually an area of DCIS. That wasn't an invasive focus. So they've done an excellent job, but occasionally you do need to go back and check. So interestingly, the AI has called it 2+, but the reason for the discrepancy between the pathologists was the moderate complete versus moderate incomplete. And on that basis, looking at the numbers, this would have actually have been a 1+ case. So the final case I'm going to present was the 2+ versus 3+. So again, that's the staining with the heat map. You can see why that was the discrepancy. So we have got intense membrane staining around some cells, but again, lots of cells showing incomplete staining. And with the heat map, we've got a combination of red cells or red dots, but also the yellow dots. So this is quite a heterogeneous case with variation in intensity. There were other areas where it was more obviously strong membrane staining. I must confess, I tend to be a little bit cautious if the staining's non-uniform, and in that setting I'll often err on calling things a 2+ rather than a 3+, so I get the fish result. And I think the final classification in this case was a 2+, because the number of cells with intense staining didn't cross that threshold, but this case was amplified on fish. So thank you very much for your attention.
Thank you so much. And for our final speaker, I invite Professor Savitri Krishnamurthy from MD Anderson, who will speak about Galen breast HER2, a computational image analysis-based decision support tool for interpreting HER2 immunostain, and some results from current and previous studies.
Thank you, Manuela. Good afternoon, everybody. So you heard about the Galen platform from the previous two speakers. So I'll try to kind of summarize some of the findings, early findings from the early investigator program at MD Anderson, and also kind of brief you about how this is useful for pathologists. So I titled my talk as a computational image analysis-based decision support tool for interpretation of HER2 immunostain. So these are my disclosures. So just as an introduction, we all know that the USCAP got updated in 2023, mainly in view of the results of the DESTINY-04 and the need for pathologists to identify HER2 low. And we all know all the issues, problems, challenges, and the discussions revolving around the identification of HER2 low. So the USCAP clearly said in their updated version in 2023 that you go under 40x and try to look at your slides for the distinction, for optimal distinction of 0 and 1+, and if possible, take a consensus review from your colleagues. And the other thing stays the same, right? The need for maintaining proper pre-analytic factors and your analytics, all that stays the same. But just to kind of help us in the identification of HER2 low, that is what they said. But having said that, as pathologists, we all know that a large part of the interpretation is subjective. So inter-observer variability is kind of a part of our daily routine work that we do. So between two pathologists, there is bound to be subjectivity. So even you take experts for something such as HER2 interpretation, the same pathologist who may be an expert may not agree with themselves. So all these are issues in the field. So what can be done in today's era? You see in this meeting, there's a lot of AI around, right, for pathology. It is coming into our field and it's already there in our field. So what can computational image analysis do for HER2 IHC assessment? So obviously, it can aid in consistent scoring and it can help us overcome the subjectivity in the interpretation of HER2 IHC for optimal interpretation of HER2 protein expression, particularly at the lower end of the spectrum. Now, I think in United States, most of us, we don't worry about borderline between 1+, 2+, 2+, 3+. We just, start doing FISH. But at the lower end between 0 and 1+, that we never paid so much attention, here are the tools available for us in today's world to create some kind of, to help us in creating an objectivity to our interpretation. So AI models can serve as ancillary aids to pathologists for evaluating HER2 IHC, and several AI models are available or in development. But none of the AI tools are approved for standard of care yet, and we hope that with the very good performance of things like the Galen HER2 platform, these will be available very soon for standard of care pathologists. So let's see, what is this Galen platform? You heard from the previous two speakers, so I don't have to go into this, but just I want to make sure that we are clear that here is a fully automated solution for interpreting HER2 IHC. There are many other kind of solutions available for bringing objectivity to HER2 that you can attach to your microscope and so on. But this platform is completely automated in that it recognizes the invasive tumor and starts annotating the HER2 immunostaining pattern in the invasive tumor and comes up with a score. But it is left to the pathologist to see whether they agree with it or whether they want to change it. But it certainly highlights the staining pattern, and you are amazed how quickly it does that and how accurate it is majority of the times. So I want to start with couple of examples and then tell you about the trial and so on. So I don't know how much it projects. I chose this case to show a punch biopsy of skin, and you can already see some annotated areas. This is the HER2 IHC of this punch biopsy. The beauty is that just when you bring it to the screen, it has already shown you the invasive areas, and it is pretty accurate in pointing the invasive areas and kind of putting a mark around it. And then when you go into one of those areas, this is a HER2 IHC stain, and you're debating, what am I going to call this, 0 or 1+? And many times when it is at the borderline, it's a judgment call that changes, either end of the spectrum. We all know in our daily practice that happens. So that is where I think if you apply the Galen platform in this, as I said, it has nicely annotated your invasive tumor area. And on the side, you see how it clearly tells you the annotation. So if a cell is 0, it is these blue kind of rounds. If it is faint, incomplete membrane staining, that is either faint or barely perceptible, it is a green circle. And if it is moderate, like, of low intensity, it is yellow. So on the side, it tells you clearly what is what. And at the end, on the top, it scores all that and gives you a proper score. Like say, for instance, in this case, when you looked at just the HER2 IHC, many things you think, oh yeah, this is perhaps 1+. But when you put the Galen, it clearly tells you that the faint scoring is only in 7.97% of cells. And that really is very useful for us to finally say, okay, I agree that this is 0 and not 1 plus. This is another image that I wanted to show you. If you look at the plain HER2 IHC, you see the very few, like see, let me put the cursor. See, these are the cells with very incomplete staining, just few here and perhaps something here. And see how exactly it matches. This is at a higher mag, the Galen platform, the same incomplete membranous staining you see beautifully with these green rounds exactly in that area. And the one very little here is shown as 1 dot here. So clearly this is a score 0 case, but I want to show this to show how accurate it is in pointing out to these incomplete membranous staining area that you can match beautifully. And when you are using this platform, you can go in and out of the annotations. That means you want to match and see. So you just do the press space bar, then you just get your the HER2 immunostain, and you just remove the space bar. It shows you the green and blue dots, making it very easy for you to kind of reconcile with the real staining pattern. Okay, another thing that I find useful that pathologists need to know, I feel, is, the difference between surgical excision interpretation and core biopsy, particularly at the lower end of the spectrum. When you have a big surgical excision stained with HER2, doing under 40x and seeing carefully everywhere takes time. It is labor intensive, and even after looking at everything, you're not very sure, because by the time you have screened the whole thing, you think, oh, is it 10% or more? You kind of get a little confused. I feel here it really is useful for excisions. So here is this case. So if you start looking just at the immunostain, it looks like there are many 1 pluses in this. And it's a large area, right? It's a big surgical excision. And here is the Galen applied in this, and it clearly kind of highlights the real 1 plus in this large area of the entire excision. Finally, this case came out as 0 and not 1 plus, although like many pathologists, when you look at the whole thing, it can go either way, but many would have called it 1 plus. So with that example, I want to kind of tell you a little bit about the early evidence program, which in my view is very, very important, because an initial study was done with 120 cases alone, including 5 expert breast pathologists as ground truthers and 4 general pathologists as readers. So to take the evidence even further, I think this study was designed with 15 centers, each centers providing at least 100 to 200 cases, having a real-world distribution of HER2, like 15 to 20% positive, 80 to 85% negative. So the design of the study is that having 2 reader pathologists in each center and in 2 arms, a manual scoring arm with no AI and an arm B where you have like the Galen as an additional decision support tool for the pathologist. And the ground truthers includes 2 expert breast pathologists with a 3rd pathologist being an arbitrator when there is discordance between the 2 expert pathologists. So in MD Anderson, I wanted to kind of show the value of excisions versus core, also the time taken, digital versus manual, because in my mind, I think, there is a difference between reading slides manually versus digitally. That itself is important because now many labs, many practices are considering transitioning to full digital. Some have become full digital. My practice is, all digital is available, but we still do manual. Because with my other digital pathology studies, I clearly kind of find a difference between manual and digital with respect to time taken and, the user friendliness and so on. So I wanted to study that too. So in my center, we have surgical excision 41%, biopsy 59%, and the distribution is like standard, 3 plus was 14%, 0 is 32%, 2 plus 19%, and 1 plus 35% based on the standard of care pathologist sign out, and mine is a very big team. And the invasive carcinoma was ductal in 61%, lobular in 19%, and total number of cases from 200, I think 2 had to be removed, so it's 188. So this is early results. I think some of the results will be presented in ASCO in a couple of months, but these are the early results from my center. So what I just want to stress is that most important is ground truthers. There was only 77% agreement amongst the two ground truthers for the digital HER2 IHC slides, which is similar to what is reported, but these are the breast experts. So for biopsies, it was 78.9%, and sure enough, for excisions, it was lower, which is what I thought. It is, so it creates the data, 74.4%. So overall, if you look at my center, these are early results. The analysis is still going on. What I want to stress is that if you took all cases, for the readers, two readers, between not using AI and using the Galen as a decision support tool, there is a big difference. Look at it. The first row, 69.4% versus 81.8%. That tells you a lot that, yes, a decision support tool does help the general pathologist in coming to a consensus with themselves and producing more objective results. So I want to show some cases from our study. So this is a case, a core biopsy, invasive ductal carcinoma. The two ground truthers called this 1+. One reader called it 2+. Another reader said 1+. So obviously, you know, if you look at this case, it is like on the borderline, but I think decision supports tool would be useful in this case. So clearly, as I said, the invasive carcinoma is nicely annotated. And I feel this is an edge of the Galen compared to other platforms that are currently available commercially in the market right now. So I think if you look at this, clearly the green dots, the green circles are your incomplete membranous staining. The blue is no staining. So clearly this case came up as incomplete membranous staining in 47% of the tumor cells. So obviously the second reader who called it, who did not call it 1+ with AI, clearly called it 1+, so that all four of them became consistent. Here is another case. Two of the ground truthers called it 0. The reader, one reader called it 1+, another called 0 without AI. And you can see the Galen application clearly shows that majority of the circles are all kind of blue. There is very little 1+. And quantitating it, it clearly said 3.36% 1+. So obviously this case is a 0. So again, it helped all the four people come to a consensus. So this is another case. So this is the same case. I think trying to show at higher magnification, highlighting those very few green dots to the pathologist who perhaps overcalled first time around, but changed back again, rightly so, so that all four became 0. So I just want to point out, in the previous study that was presented in USCAP, the manuscript is nearly done. So this was a 120 study done with, as I said, 5 expert breast pathologists as ground truthers and 4 as general pathologists. And absolutely, even in that study, it became very clear that if you took the average agreement of the 4 general pathologists with the high confidence ground truthers, that means 4 out of the 5 ground truthers, if they agreed with the diagnosis, was considered high confidence ground truth. So it is not necessary that all 5 were positive, because in a small percentage, some did not agree. But anyway, for the 4 pathologists, if you took all the 92 cases from that study with high confidence ground truth, without AI, the concordance was 85.3%, and with AI, it became 88. So there was improvement. But amongst the 4 pathologists, with and without AI, was really a big jump, 69.7% versus 77.2%. So obviously, so what does that tell us? So if you looked at lower end of the spectrum, like 0 and 1+ cases, with and without AI, for the general pathologists, it jumped from 69.8% to 87.4%. So basically, using the Galen platform or AI computational image analysis as a decision support tool, there is higher agreement with the expert ground truthers. But more importantly, it creates higher inter-observer concordance for the pathologist. So with AI and without AI is particularly useful for cases at the lower end of the spectrum, 0 and 1+ kind of cases. So at the end, so in summary, The Galen breast HER2 platform as a computational image analysis decision support tool can provide the much needed ancillary aid for interpreting HER2 IHC, is particularly useful for finalizing the borderline staining result cases. Also, I would like to point out it is useful for evaluation of HER2 IHC performed on surgical resection and with lower level protein expression. And the bottom line is this tool can improve interpathologist concordance in HER2 IHC scoring, which is very much needed in the field. So it is a fully automated solution. It helps in recognition of the invasive tumor, next step annotation of the individual tumor cells, and finally providing you with a USCAP 2018/2023 guideline update kind of a score for you. But it is not that you have to just take it as like ground truth. You can check it and reconcile with yourself and agree and then make your final reporting. So performance is agnostic to the antibody used and the lab performing the stains and the scanner that is used for obtaining the whole slide image. I find this very important because many of the other platforms that claim can do the HER2 interpretation, they do not have these advantages. So I think that is very useful, and I would like to point that out. And it can serve as a very robust ancillary decision support tool for HER2 IHC interpretation. So I think all the evidence, so we have to stay tuned for the results of the entire 1,000 cases, which will create more kind of robust evidence for us in the field that computational image analysis will bring the much needed objectivity for the interpretation of HER2 IHC, irrespective of the results of Destiny 06 or the DAISY correlative studies, because the science will evolve with respect to HER2 low. Is it really a great science or whatever it is? But the need for a computational tool for pathologists is here to stay, in my opinion. So with that, I end my talk. And I think there are many people involved in doing all this work from my center, and they are all listed here. Thank you very much.